Good evening, Dr. Phil here. Today we will be discussing on the neuromuscular junction. The neuromuscular junction is a chemical synapse formed between the motor neuron and its muscle fiber. The events occurring at the neuromuscular junction: number 1, an action potential arrives at the presynaptic terminal, and this causes voltage-gated calcium channels in the presynaptic membrane to open. Number 2, calcium influx into the presynaptic terminal occurs via the voltage-gated calcium channels, and this stimulates the release of acetylcholine from the synaptic vesicles into the synaptic cleft. This involves the activation of many proteins such as synaptotacmin, syntaxins, synaptophysin, and synaptobrevin. Synaptobrevin is inhibited by botulinum toxin, which prevents acetylcholine release and muscle contraction. Prejunctional nicotinic cholinergic receptors modulates acetylcholine mobilization and release via a positive feedback mechanism. Number 3. Acetylcholine is released into the synaptic cleft via exocytosis. Number 4. Acetylcholine diffuses across the synaptic cleft and binds the post-junctional nicotinic receptors on the postsynaptic membrane, which is a ligand-gated sodium channel. This channel consists of 5 glycoprotein subunits characterized as alpha, 2, beta, delta, and epsilon, which forms a central ionopore. One molecule of acetylcholine binds to one of the 2 alpha units, and this facilitates the binding of a second, during which the receptor undergoes a conformational change and the ionopore opens. Each acetylcholine only interacts with an alpha unit only once before being broken down. Number 5. The ligand-gated sodium channels open, and sodium influx occurs in the postsynaptic cell, causing depolarization of the cell membrane. An action potential is generated along the postsynaptic membrane if the depolarization exceeds a certain threshold. Number 6. Acetylcholine unbinds from the ligand-gated sodium channel, which then closes. Number 7. Acetylcholinesterase attached to the postsynaptic membrane breaks down acetylcholine into acetic acid and choline. Acetylcholine in the cleft is broken down by acetylcholinesterase at the cleft within 100 microseconds after acetylcholine interaction with an alpha unit. Choline is symported with sodium into the presynaptic terminal. Acetic acid diffuses away from the synaptic cleft. Choline is recycled to make new acetylcholine, and the synthesis of acetylcholine in the motor nerve terminal is catalyzed by choline O-acetyl transferase. Acetylcholine is formed from the acetylation of choline, and ACH is stored in vesicles which lie just within the axonal prejunctional membrane. Lastly, number 9. Acetic acid from metabolism and recycled choline constitutes new acetylcholine molecules in the presynaptic terminal. ACH is then taken up by synaptic vesicles. This diagram summarizes the processes leading to muscle contraction. Number 1. An action potential arrives at the presynaptic terminal. Number 2. Calcium channels open and calcium enters the presynaptic terminal. Number 3. Acetylcholine released from the presynaptic vesicles into the synaptic cleft. Number 4. Acetylcholine stimulates sodium channels in the postsynaptic membrane to open. Number 5. Sodium diffuses into the muscle fibers. Action potential initiated and travels along the sarcolemma and the T-tubule membranes. Number 6. Action potentials in the T-tubules causes the sarcoplasmic reticulum to release calcium. Number 7. Calcium binds to troponin on actin, which moves tropomyosin and exposes the myosin head attachment sites. Number 8. ATP on myosin heads are broken down to ADP and P, which releases energy for movement of the myosin heads. Number 9. The heads of the myosin filaments bend towards the M line, causing actin to slide past myosin. The cycle repeats as long as calcium is present. For neuromuscular blockers, refer to the video on the discussion on neuromuscular blockers. Myasthenia gravis. Anesthetic considerations. Myasthenia gravis is an autoimmune disease where antibodies are formed against the post-junctional acetylcholine receptor and is characterized by muscle weakness and fatigability. Decrease in effective receptors results in muscles which are easily fatigued on repetitive exertion. Up to 80% of functional receptors are lost prior to symptoms occurring. There is high potential for respiratory failure. Post-operative ventilatory support may be needed in as many as 30% of subjects. Bulbar involvement will increase aspiration risk. There is sensitivity to non-depolarizing neuromuscular blockers. Initial doses should be around 1/10 of normal. A propofol and remifentanil technique may allow avoidance of neuromuscular blockade altogether. There is resistance to suxametonium, and a higher dose of suxametonium at 2 mg per kg is usually needed to allow good conditions for intubation. Possible thymoma and anterior mediastinal mass, which may impede intubation. Myasthenic crisis can be precipitated by various physical and emotional stresses, or it could be spontaneous, and this results in exacerbation of symptoms severe enough to cause respiratory failure. Cholinergic crisis is precipitated by an overdose of anticholinesterase. Excess ACH stimulates muscarinic receptors and acts as a neuromuscular blocker at the diminished number of receptors, leading to muscle weakness and respiratory compromise. Adrophonium, which is a short-acting anticholinesterase lasting about 5 minutes, transiently improves a myasthenic crisis and worsens a cholinergic crisis. History. We should ask about the duration and severity of the weakness. Grading of the severity. Type 1 involves primarily extraocular muscles. Type 2A, mild and slowly progressive, sparing the respiratory muscles. Type 2B, more severe and rapid, involving the respiratory muscles. Type 3, acute onset with rapid deterioration. And Type 4, severe generalized. We should ask about respiratory symptoms such as shortness of breath, orthopnea, which could signify mediastinal mass, symptoms of pneumonia and infection, etc. Stress fatigue, such as weakness on arm abduction and upward gaze, and current treatment, which may include cholinesterase inhibitors, steroids, immunosuppressants, thymectomy, and plasmapheresis, which depletes plasma esterases and prolongs the effect of drugs metabolized by plasma esterases, such as suxametonium, mivacurium, ester-linked local anesthetics, remifentanil, and esmolol. On physical examination, we should try to detect signs of chest infection, muscle weakness, which is fatigable. It can be demonstrated by asking the patient to chew a chewing gum, and the muscles of mastication fatigues. The diagnosis can be supported by testing with adrophonium as well. Electromyographic stimulation of myasthenic patients reveals fade. We should look for signs of other autoimmune diseases such as SLE, rheumatoid arthritis, and hypothyroidism. Investigations. Preoperatively, we should order electrolytes such as potassium. If there is hypokalemia, it can exacerbate weakness. Pulmonary function tests such as FEV1, FVC, and PFR are valuable. Blood glucose levels if the patient is on steroids. Options for anesthesia includes regional anesthesia, which is preferred, general anesthesia without neuromuscular blockade with or without epidural, and the least desirable is general anesthesia with neuromuscular blockade. There is a conflict between the need for neuromuscular blockade versus the difficulty of using neuromuscular blockade and associated weakness. Measures to optimize outcome. If there is severe weakness preoperatively, consider plasmapheresis. Avoid giving more cholinesterase inhibitor than the usual daily dose to avoid risk of cholinergic crisis. 1 mg of IV neostigmine approximates to 30 mg of oral pyridostigmine. Be cautious with pre-op sedation, pre-medication with gastrointestinal aspiration prophylaxis and steroid cover, rapid sequence induction if there is risk of aspiration. Inhalational anesthetics reduces neuromuscular transmission by up to 50%, and this may avoid the need for neuromuscular blockade. Intravenous anesthetics have no clinical effect on neuromuscular transmission, and propofol and remifentanil technique may allow avoidance of neuromuscular blockade. Ester-linked local anesthetics may have a prolonged action and increased toxicity with anticholinesterase therapy and plasmapheresis. Exacerbation of myasthenia may occur. Use minimum dosage for local anesthetics when giving blocks. Emergence. Extubate fully awake with full return of baseline strength, which can be indicated by head lift of more than 5 seconds or guided by a nerve stimulator. Staged weaning from ventilation is necessary in certain patients. Risk factors for requiring post-operative mechanical ventilation includes pyridostigmine dose of more than 750 mg per day, disease duration of more than 6 years, vital capacity of less than 2.9 liters, coexisting chronic lung disease, upper abdominal surgery, blood loss more than 1 liter, and major body cavity surgery. Multimodal analgesia should be employed. Reduce opioid use if possible, as it can reduce respiratory reserves. Restart cholinesterase inhibitors slowly at smaller doses. The initial dosage of neostigmine should be used under nerve stimulator control, starting with a 2.5 to 5 mg bolus and increasing if necessary with a 1 mg bolus every 2 to 3 minutes to a maximum equivalent dose to the oral pyridostigmine dose. Watch out and treat for myasthenic and cholinergic crisis. Next, we move on to Eaton-Lambert syndrome. Anesthetic considerations. There is presence of antibodies to voltage-gated calcium channels and to the associated protein synaptotacmin, and this results in reduction in presynaptic acetylcholine release. The postsynaptic membrane sensitivity is normal. The muscle weakness improves with activity, unlike myasthenia gravis. About 2/3 of the cases, this condition is associated with malignancy, classically bronchogenic carcinoma. Muscle weakness may predispose to respiratory failure after anesthesia and might require post-operative positive pressure ventilation. Patients are very sensitive to both succinylcholine and non-depolarizing muscle relaxants, and autonomic dysfunction is present in about 30% of the patients. History taking. There is proximal lower limb weakness. Muscle power improves with exercise. Neostigmine produces little or no improvement. Symptoms of autonomic dysfunction includes dry mouth, ptosis, urinary retention, and constipation. Physical examination. We should look out for reduced or absent lower limb reflexes, orthostatic hypotension, and impaired accommodation of the eyes. Investigations. Serology for antibodies to voltage-gated calcium channels and synaptotacmin. Chest X-ray and CT chest to look out for lung cancer. Electromyography characteristically shows reduce amplitude on low frequency 2 Hz stimulation and increase amplitude on high frequency or 50 Hz stimulation. Optimizing outcomes. Regional anesthesia may be the best option. Counsel and prepare for possible post-op positive pressure ventilation. Intravenous immunoglobulin 2 gram per kg over 2 days increases muscle strength, peaking at 2 to 4 weeks and declining by 8 weeks. Alternatively, 400 mg per kg per day for 5 days preoperatively. Minimize the use of neuromuscular blockers. This may prevent post-operative PPV and titrate carefully using a nerve stimulator if neuromuscular blockers are used. Post-atonic count is better to monitor the degree of blockade rather than train of thought. Be cautious with myocardial depressants and vasodilating drugs, as patients may be having autonomic neuropathy and this risks hypotension. Extubate fully awake with minimal weakness or ventilate post-op at the ICU for weaning. These are my references. Thank you.